Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to the Solid Anatomy lecture on circulation. I'll be back later for a clinical correlation and the end of session quiz, but for now I'm going to turn it over to our primary lecturer, Dr. John Phelan.
The source of oxygenated blood to the fetus is the placenta, an organ within the uterus that is connected to the fetus via the umbilical cord. Within the umbilical cord is a single umbilical vein delivering oxygenated blood to the fetus and a pair of umbilical arteries that drain deoxygenated blood from the fetus back to the placenta. In the embryo, bilateral umbilical veins are initially present, but the right one regresses at about the 6th week of development. The remaining umbilical vein enters the fetal liver and drains into the left branch of the portal vein, which brings blood into the liver from the as yet inactive fetal gut. Proximal to the point where it joins the portal vein, there is a vessel connecting the umbilical vein to the inferior vena cava, the ductus venosus. It is often described as a shunt because it allows oxygenated blood to bypass the liver and go directly to the heart. About half of the blood traveling in the umbilical vein passes through the ductus venosus. This oxygenated blood mixes with the blood in the inferior vena cava, which is deoxygenated blood from the inferior part of the fetus, and enters the right atrium of the fetal heart. There is an opening in the fetal interatrial wall called the foramen ovale that is covered by a flap of tissue that forms a one-way valve. During embryonic development, there is initially a single atrium that undergoes septation, or division into a pair of atria by the development of a septum. Septation of the atrium occurs in 2 stages and results in an interatrial wall formed by a pair of incomplete overlapping septae, the septum secundum and the septum primum, that are named according to the order in which they are formed. Part of the septum primum forms a flap that covers the defect in the septum secundum on its left atrial side. When the right atrium contracts, the blood pushes through the opening in the septum secundum against the flap formed by the septum primum. The flap moves away from the septum secundum and into the left atrium, allowing blood to pass from the right atrium to the left atrium through the resulting opening in the interatrial wall, which is called the foramen ovale. When the left atrium contracts, blood pushes against the flap, bringing it into contact with the septum secundum, thereby closing the foramen ovale to prevent backflow of blood from the left atrium into the right atrium. Remnants of embryonic structures at the opening of the inferior vena cava in the right atrium form a valve that directs blood flow from this vessel towards the foramen ovale. Thus, the majority of the partially oxygenated blood from the inferior vena cava passes through the foramen ovale to the left atrium, rather than through the tricuspid valve to the right ventricle. The foramen ovale is also referred to as a shunt because it allows oxygenated blood to bypass the inactive fetal lungs and flow directly to the left side of the heart to be pumped to the fetal body. Deoxygenated blood from the superior part of the fetal body, entering the right atrium through the superior vena cava, is directed towards the tricuspid valve rather than the foramen ovale, and thus passes mostly into the right ventricle. The right ventricle pumps blood through the pulmonary trunk, which bifurcates into the left and right pulmonary arteries. Pulmonary resistance is very high compared to systemic resistance in the fetus, so very little blood flows into the fetal lungs. The fetal lungs are not fully expanded, which results in compression of the distal ends of the pulmonary vessels, and the relatively hypoxic nature of fetal blood is thought to cause vasoconstriction of the pulmonary arteries. Most of the blood in the pulmonary trunk flows into the arch of the aorta through the ductus arteriosus, which allows blood to bypass the lungs and flow directly into the systemic circulation. The descending aorta bifurcates into the left and right common iliac arteries, each of which, in turn, bifurcates into an internal and an external iliac artery. If you've watched the solid anatomy lectures on the pelvis, you may recall that one of the branches of the internal iliac artery is the umbilical artery, which travels along the inner surface of the anterior abdominal wall to reach the umbilicus. The umbilical arteries pass through the umbilical cord in the fetus to return blood to the placenta. Upon the fetus's first breath at birth, the lungs expand, stretching and straightening out the pulmonary arteries, thereby lessening their resistance to blood flow. The pulmonary arteries dilate further in response to the increased oxygenation of blood as respiration begins. This decrease in pulmonary resistance causes a sudden drop in pressure in the right atrium. Meanwhile, the higher pulmonary venous return to the left atrium from the active lungs causes an increase in pressure in this chamber. This reversal in pressure causes the valve of the foramen ovale to close. This valve usually becomes permanently sealed over the first year of life by the development of fibrous tissue. The indentation in the interatrial wall of the adult formed by the sealed foramen ovale is called the fossa ovalis. The walls of the ductus arteriosus react to the higher oxygen concentration of the blood by constricting. This vessel usually loses its patency a few days after birth and becomes the ligamentum arteriosum in the adult. Severing the umbilical cord eventually results in the collapse of the umbilical vein and the ductus venosus. The umbilical vein becomes the ligamentum teres in the adult, which runs between the liver and the anterior abdominal wall, enveloped in the falciform ligament. The ductus venosus becomes the ligamentum venosum, which can be observed on the posterior side of the adult liver in the groove between the caudate and left lobes. The distal ends of the umbilical arteries become obliterated and form the medial umbilical ligaments in the adult, while their proximal ends remain patent and may give off branches in the pelvis.
All right, it's time for one of those clinical correlations. So let's spend a little time talking about the circulation a little bit more. And when a baby is born and takes its first breath, there are a few things that need to occur in order for the fetal circulation to adapt to a life outside of the uterus and away from the placenta. Now, as a baby draws its first breath, this will suddenly cause a drop in the resistance of the pulmonary vasculature. Now, the baby's chest will move in a way to drop that intrathoracic pressure. Now, this draws air into the lungs. Now, think about how during the past 9 months these lungs were being bypassed. During fetal life, there's no oxygen being inhaled into the lungs. Therefore, there's no reason for the fetal circulatory system to direct and pump blood through those lungs. Now, following birth, two main things will need to happen within the thorax to give you that adult style of circulation. We discussed the foramen ovale earlier. Now, the foramen in the heart acts as a right to left shunt into the fetus. Now, it's formed by overlapping septa, the septum primum and the septum secundum. Now, as the baby's intrathoracic chest pressure drops, it causes the two flaps to press together. And the pressure in the left atria is now higher than the right. And this so leads to a pressurized closure of that foramen ovale. Now, over time, this foramen should permanently close. Now, the other fetal shunt in the heart that needs to close is the ductus arteriosus. In the fetus, this shunt helps oxygen-rich blood bypass those lungs and go down that fetal aorta. Now, after birth, the high oxygen concentration in the blood actually causes lower prostaglandin levels. And those prostaglandins keep the ductus arteriosus patent or open. Now, in some cases, such as in a congenital heart defect, you may actually want to keep that PDA open for a little bit longer. And in order, you do this in order to diagnose that problem and maybe to surgically treat it in some cases as well. Now, to do this, drugs may be given to actually raise the level of prostaglandins. Now, this way, the baby will be able to use some of that oxygen-rich blood while medical decisions are then being made. All right, so let's go through a few of these questions. First question here, to keep the ductus arteriosus open in some cases, what drug do you give to artificially keep the baby's prostaglandins elevated? So we didn't go over this, but the answer is misoprostol. So this is a prostaglandin analog. Next, what drug may be given to close a patent ductus arteriosus? And that's going to be indomethacin, because that's going to inhibit those prostaglandins. And since we talked about the foraminal valley, let's spend a little bit more time talking about the atrial septal defects. So what is an ASD? Well, this is obviously referring to an atrial septal defect, and this is an incomplete closure of the oval foramen. Now, this foramen is the hole between the right and the left atria. Now, we discussed normal development of the septum primum and secundum, which results in the atrial septum in the adult. Now, when this process fails to stop blood flow from the right to the left atria, the result is a patent foramen ovale. Now, if the atrial septal defect is small, often this is asymptomatic and requires no treatment at all. However, in the event of a clinically significant ASD, blood is pathologically shunted from the high pressure of the left atrium to the low pressure of the right atrium. Now, over time, this leads to dilation and hypertrophy of the right side of the heart, and this is going to be known as pulmonary hypertension. Now, many defects are now repaired with newer, non-invasive treatments performed by interventional radiologists, and that's by closing the gap between the atria with some sort of umbrella-shaped device. All right, so let's go over a few questions here. What is an ASD? So this is an incomplete closure of the oval foramen, so this is the hole between the right and the left atria. Next, what are the three possible causes of an atrial septal defect? So we have an ostium secundum, so this gets too big and overlaps the foraminal valley. You have absence of the septum secundum, and then neither the septum secundum nor the septum primum develop.
After birth, the lungs are the source of oxygenated blood. The pulmonary trunk from the right ventricle divides into the right and left pulmonary arteries that bring deoxygenated blood to the lungs. Gas exchange occurs in the capillary beds overlying the alveoli in the lungs. Pulmonary veins return oxygenated blood to the left atrium, which transfers it to the left ventricle, which pumps it through the aorta to ultimately reach the multitude of capillary beds throughout the body. How then are oxygen and nutrients in the blood transferred to the cells of the tissues of the body? The arterial system ends and the venous system begins in capillaries, which are the smallest unit of the circulatory system. Capillaries are just one epithelial cell thick, and the spaces between these cells allow the exchange of materials with the interstitial or extracellular fluid. Capillary beds are networks of capillaries that connect arterioles, which are the smallest arteries, with venules, which are the smallest veins. As blood is forced into capillary beds through arterioles, fluid containing oxygen, nutrients, and other cellular materials is pushed out of the capillaries into the extracellular spaces, allowing exchange with cells of the surrounding tissue. It is thus said that hydrostatic pressure drives fluid out of capillaries. The pores in the capillary walls are too small for blood cells to pass through, and they are relatively impermeable to plasma proteins. At the venous end of the capillary bed, osmotic pressure created by the high concentration of protein within the capillary drives most of the extracellular fluid, now containing waste products and carbon dioxide from the cells of the tissue, back into the capillaries. Perhaps this description has reminded you that Starling's hypothesis is at work here. It states that movement of fluid across capillary walls is dependent upon a balance of hydrostatic and osmotic forces. Not all of the fluid driven out of the arterial side of the capillary bed is reabsorbed by the venous side. Some of the fluid remains in the extracellular spaces. Without a means to drain this excess fluid out of the extracellular spaces, edema would occur. Luckily, the lymphatic system drains this fluid back into the bloodstream, along with plasma proteins that leak out of the capillaries, and debris from cellular decomposition and infection. The fluid, which is called lymph, is similar in composition to blood plasma. Lymph enters lymphatic capillaries that end blindly in the extracellular space of most tissues amidst the capillary beds. The lymphatic capillaries drain into lymphatic vessels that enter and exit small masses of lymphatic tissue called lymph nodes. Macrophages and phagocytes within the nodes filter the lymph by absorbing particulate matter. Inflammation of lymph nodes is an important harbinger of injury or disease. Lymph nodes are found throughout the body, but there are palpable concentrations of lymph nodes in the cervical, axillary, and inguinal regions. If you dissect a cadaver in conjunction with your anatomy course, prepare to see a large concentration of lymph nodes in the region of the bifurcation of the trachea. These are the tracheobronchial lymph nodes that filter lymph from the heart and the lungs. The lymphatic drainage of the skin may be generalized as follows. Lymph from the skin of the head and neck drains into the cervical lymph nodes. Lymph from the skin below the umbilicus drains into the inguinal lymph nodes, and lymph from the remaining skin drains into the axillary lymph nodes. Lymph from the skin then drains into lymphatic vessels deeper in the body. Lymphatic vessels join to form 5 major bilateral lymphatic trunks that either drain independently into the venous system or join the right lymphatic duct or the thoracic duct to drain into the venous system. The lumbar trunks drain lymph from the lower extremities, pelvis, and urogenital system, and parts of the abdomen, to the cisterna chyli, a dilated area that forms the origin of the thoracic duct. The intestinal trunks carry lymph from the gut to the cisterna chyli. The bronchomediastinal trunks carry lymph from the thorax to the right lymphatic duct on the right side and the thoracic duct on the left, although one or both may directly enter the venous system at the level of the subclavian veins. The subclavian trunks drain the upper extremity. The right usually opens into the right lymphatic duct, while the left often opens directly into the venous system in the vicinity of the internal jugular and subclavian veins. The jugular trunks drain lymph from the head and neck. The right jugular trunk may open into the right lymphatic duct, but both the right and left often open directly into the venous system at the junction between the subclavian and internal jugular veins on their respective sides. As previously stated, the thoracic duct begins in the abdomen in a dilatation called the cisterna chyli and runs superiorly through the aortic hiatus to enter the mediastinum. It passes between the azygous vein and the aorta and terminates in the neck. The right lymphatic duct and the thoracic duct enter the venous system on opposite sides of the body near the junction of the internal jugular and right subclavian veins. Generally speaking, the right lymphatic duct drains the right upper quadrant of the body, while the remaining 3/4 of the body are drained by the thoracic duct. Lymphatic circulation is driven by compression of tissues surrounding the lymphatic vessels. For instance, sitting down on a chair compresses the tissues of the gluteal region, pushes the extracellular fluid into the blind-ending lymphatic capillaries, and squeezes the lymph through the lymphatic vessels. Numerous one-way valves keeps the lymph flowing towards the termination of the lymphatic vasculature in the venous system. Contraction of skeletal muscle has the same effect, while immobility leads to a decrease in lymphatic circulation that manifests as edema.
All right, so that covers the basics of fetal circulation, capillaries, and lymphatic circulation. Now I want you to pause the video and answer the end of session quiz questions. Now, there will be some questions addressing additional high-yield concepts that may not have been discussed in the lecture. Just do the best you can, then we'll go through those answers together. Let's get going. First question here. What blood vessel delivers oxygen to the fetus? So this is going to be a single umbilical vein is going to deliver that oxygen-rich blood to the fetus, and then a pair of umbilical arteries are going to drain that deoxygenated blood from the fetus back to the placenta. Next, what closes the ductus arteriosus after birth? So this is going to be high oxygen tension and that decrease in prostaglandin levels. Next, what drug can be given to close a PDA? So think of indomethacin. And why does it work? Because it's inhibiting prostaglandins. Next, what part of the body does the right lymphatic duct drain, and where does it drain? So you get the right head, the neck, the arm, and the thorax, and this flows into the junction of the right subclavian vein and the internal jugular vein. Next question, what part of the body is drained by the thoracic duct, and where does it drain? So this is basically the rest of the body. So the lower extremities, the pelvis, the abdomen, the left head, neck, arm, and thorax. And this is going to flow into the junction of the left subclavian vein and the internal jugular vein. Next, what are the two overlapping septa in the interatrial wall during fetal development of the heart? So this is going to be the septum secundum and the septum primum. Next question. What is the purpose of the two overlapping septa in the single developing atria? So this is to prevent backflow of the blood into the right atrium. So remember, when the right atrium contracts, blood pushes through the opening of the septum secundum against the flap formed by the septum primum. Now, then that flap is going to actually move away from the septum secundum and into the left atrium, allowing blood to actually pass from that right atrium to the left atrium through that foraminal valley. Now, when the left atrium contracts, blood pushes against the flap, bringing it into contact with the septum secundum, which closes the foraminal valley and prevents backflow of blood into that right atrium. Next, what is the term for excess lymphatic fluid which is not drained from the extracellular space? So this was not discussed in the lecture, but this is called lymphedema. Pretty easy there. You'll see it all the time clinically. Okay guys, so we're almost done. We have provided some images for you to label. Recalling these images in a time setting will help you do well on your practical part of your examination. So label those images and then we'll be finished. Thanks.